excellent speaker today, Dr. Jamil Kendall from Parkview Orthopedic Group right here in Oak Lawn, nice and easy. He will give us a presentation on hip and knee replacements. I saw a couple of you model in here today. I know, I'm walking like this lately too. Right, not fun. But Dr. Jamil definitely knows how to fix a lot of those problems, and he will give us a great presentation tonight. He did his fellowship at Rush University Medical Center here in Chicago on adult joint reconstruction. His residencies were in Oregon Health Sciences University School of Medicine of Orthopedic Surgery, and his medical school was obtained at Howard University College of Medicine. He is affiliated with Advocate at Christ and South Suburban Hospital. So we'll let him take over for you. And all of you should have received a program list of our upcoming programs. If you haven't, raise your hand up and do another. And then also a white form to fill out. Even if you don't want to fill it out, you just hand it to me when you return. I really just like to know how we run our programs that we doing those things.
You go to the hospital, lots of fires.
Yes.
Everywhere you go.
Okay, that's what he said. Everyone's coming up to him saying, I saw your face. So, it helps, right? Alrighty, well, thank you for coming. Thank you.
Hey everyone, how's it going? Good evening. Thank you so much for coming. Hopefully I can share some information with you guys, and this can be a helpful talk, and any questions that you haven't answered at the end, we'll get a chance to go over that. Thank you so much for the introduction, Sue. My name is Jamil Kendall, and I'm a orthopedic surgeon here in the area. And so really excited to give this talk. So I'll get started. So this is a brief overview of what we'll be talking about today. Talk a little bit just about joints. What are joints? What is, joint pain? What causes it? What the initial assessment is like when you go to see your doctor about it. What kind of treatments that aren't surgery exist, and then a bulk of the talk will be about hip and knee replacements, and then kind of what to expect around the surgery, but also what to expect afterwards. So Sue gave me a great introduction, but my name is Jamil Kendall. I was born in the Virgin Islands, born and raised there through high school. I went to Georgetown University for college, stayed in the DC area for medical school at Howard, and then went out to Portland for residency. I then came to Chicago for fellowship, focusing on hip and knee replacements. And my wife and I really just love the area and wanted to stick around. And so we've settled here in the Chicagoland area, and I joined Parkview Orthopedics. I go to our Oak Lawn and to our Palos Heights offices. And so this is kind of my bread and butter area here. I go to Advocate Christ as well as South Suburban hospitals. I also go to, our practice is also affiliated with Northwestern Palos Hospital, so I go there as well. So getting into a healthy joint. A joint is where one bone meets another bone at its most basic. And what joints do is they absorb shock and they allow for movement in the body. And so the joint is made up of bone, of cartilage, which is the soft tissue at the end of the bone, ligaments that help to balance the joint, and then synovial fluid, which gives lubrication to the joint. Okay. So on the left, we have a knee, and on the right, we have a hip. So on the left, we can see there's a femur bone, and the white is the cartilage at the end of that bone. The big beige dome in the middle is your kneecap. And then you have the tibia or the shin bone on the bottom. And then you have different ligaments and your meniscus and things like that. Now on the right, for the hip, you have the ball, which is the femoral head, and you have that white on the ball, which is all the cartilage. And then you have the acetabulum, which is basically the cup, and there's cartilage there as well. And then you have the thigh bone, the femur, and then the pelvis is what the cup is attached to. So people ask me all the time, what are the things I need to do to keep my joints healthy? Most of it is about keeping yourself healthy. So staying active, walking, biking, swimming, activities like that. They put less stress on the joints to keep them moving and keep them strong. Keeping the muscles around the joints strong also help to keep pain in the joints low. Keeping a healthy weight is very helpful. Every pound is 4 pounds on the joints. So losing 5 pounds is 20 pounds of decreased force on the joint. So it is really helpful for what your body experiences. And then eating healthy foods, balanced diet with anti-inflammatory foods, vegetables, fruits, whole grains, those sort of things, and then limiting processed foods. So you've done all that, but something is wrong. Your knee hurts, your hip hurts. Things that people describe when they're having issues with their joints, they have pain that comes and goes. There wasn't an injury, they didn't hurt it, they just kind of woke up and they have a lot of pain. Hip pain, people often think is on the outside or in the butt area. It's really in the groin. Groin pain usually signifies to me pain in the hip joint. Knee pain can be on the inside. That's probably the most common. Can be on the outside. It can be in the front. People often complain of pain with stairs or difficulty putting on their socks because their leg is just stiff and isn't moving the right way. Using over-the-counter medications like Tylenol, ibuprofen, topical stuff like BioFreeze. And eventually getting to a point where there are things they're not doing that they want to do because their hips or their knees hurt. And really the thing that concerns me is people making decisions because of the pain. Where the pain is almost kind of in charge of their lives as opposed to the other way around. So something is wrong, somebody's feeling something that's wrong. Sometimes this is what's happening in the joint. So this is essentially what arthritis is. On the left here, we have a picture of a healthy knee compared to a knee with arthritis. And what we see is the cartilage starts to wear away. The bone under the cartilage is exposed. When we say bone on bone arthritis, that's what we mean. Instead of the cartilage protecting that bone, we now have the bone is touching the bone because the cartilage has worn away. You develop bone spurs that cause stiffness to the joint and all these things. And in the hip, a similar process happens where the cartilage wears away, the joint space gets smaller, the hip gets stiffer, and all these things. So there are different things that can cause joint pain. Osteoarthritis is like common, I have arthritis. Osteoarthritis is that common thing that we mostly talk about. There are other stuff like rheumatoid arthritis or other inflammatory arthritis, like people with psoriasis can develop arthritis. People with lupus can develop arthritis. These sort of inflammatory type diseases. Sometimes people who have had an injury, whether to the hip or the pelvis or to the knee, can later on develop arthritis. Avascular necrosis is an issue with blood flow that you mostly see in the hip. This can cause issues in really young patients, like in their 30s, where they might need a hip replacement really young. And then sometimes it's these soft tissue injuries that can cause a lot of pain, like a labral tear in the hip or a meniscus tear in the knee. And then finally, sometimes people are just born with different shapes to their body that lead them to get to have issues earlier on. So you have pain and you're now going to see your doctor. These are some things that they might do. They'll get x-rays sometimes if there's concern for something that's not picked up on an x-ray, like a labral tear, a meniscus tear, avascular necrosis. They might get an MRI. They'll ask you questions about how long have you been having issues? Describe the pain. What are you taking for it? What have you done? What are your medical problems? That can become a really important one as we discuss how are we going to treat what you're dealing with. And then they'll do a physical exam in which they talk about, they touch to see where it hurts, what kind of motion do you have in the joint? Is there any instability in the joint? Because that can affect what we do as well. So there are various non-surgical treatment options that are available. One is physical therapy. A lot of patients don't love the idea of physical therapy. Depending on their day-to-day, it can take up a lot of time, but it really can help to make everything around the joint that's painful stronger. So that can be a helpful thing to add to a treatment program. Pain medications, usually I advise for different types of anti-inflammatories. That's like ibuprofen, Advil, those types of things. Sometimes there are prescription anti-inflammatories that I'll prescribe as well. I do try to stay away from the opioid pain medications for hip and knee pain. I find that it's not as effective as some of these other type of medications. Specifically, especially in the knee, we'll often do injections. So there are steroid injections and then gel injection, which is a high hyaluronic acid. The steroid, what it do is it decreases the inflammation in the knee joint or in the hip joint. And then the gel, it really helps to make more of the lubrication in that knee. What's in that substance is something that the body naturally produces. And so it kind of helps to jumpstart the knee into making more of that lubrication. I typically don't do gel injections in the hip, but I will on occasion do steroid injections into the hip. I find in the hip it's maybe a little less predictable, but in the right patient, it's something that I will offer. Other things, weight loss, we talked about that 1 to 4 ratio. In the knees, sometimes we do little braces to help with stability. And then assistive devices. Sometimes patients will go to a cane or a walker to help take some of the pressure off of their joints. Now, when is it time for surgery? When we've done all of the non-operative treatment options and they're no longer working. When your quality of life is being impacted. And finally, when you as a patient feel like it's something that you're physically ready to do and mentally ready to do. As although surgery is becoming more and more common, it's something that I do on a very regular basis. For you, it's something that you only do a handful of times. So you have to be ready to make that jump. And that is a big, big, big part of it. So in a hip replacement, and I have my little models here that I usually show in clinic. So in a hip replacement, basically what we do, take this out, is we put a metal piece that goes inside of the femur here, okay? And on top of that, we put usually a ceramic ball, and that replaces the ball that we remove, all right? And then on the inside of the cup, we remove all the cartilage, and we put a metal cup and then a plastic piece inside of that. And the metal and that plastic is what allows you to have a smooth moving hip. So there's some things that people tend to ask me about when we talk about hip replacements in the office. And one big thing is, which approach do you use? Do you go from the front or do you go from the back or the side? Okay. So the picture on the left is the anterior approach. Benefits from this is that instead of having to go between muscles, we go, or instead of having to go through muscle, we go between muscles. So there's an interval that we go between, and the idea is there's less damage to the surrounding tissues, potentially quicker recovery. Okay. With the posterior approach, I would say that's still probably the most common approach that you'll see. What we do is we go between the fibers of the big glute muscle in the back here, and that gives us very reproducible access to the hip joint. So the question is always, which is better? And my honest opinion is you need to find a surgeon that whatever it is that they do, they're comfortable and they're confident in the way that they do it. And it's something that they do all the time. Okay. So they feel confident in whichever approach it is that they're doing. When you find someone who may say, I don't usually do this, but I'll do it if that's something that you want, I think that's a red flag. Okay. Now for me, I actually do both. And the reason I do both is I think there are times when one is maybe better than the other. Okay, so the anterior approach, I think, is my preferred way to do it. I think it's a great way for most patients. Things that I like about it, in the room, there's a special table we use, which I think is good for my staff. I get to use X-ray really easily, which helps me put everything exactly where I want to put it. I think for the patients, the big thing is there are no special position precautions after surgery that you have to worry about, and there's a low risk of dislocation. Now, when do I do a posterior approach? For patients with bigger body habitus, because the anterior approach sometimes can have little wound issues, I think it can be a good option for those patients. Anyone with any really complex anatomy, I think the posterior approach is really good. If you've had surgery before, when I'm doing a redo surgery, I usually do it from the posterior approach. What I found is most patients with hip replacements do really well. I think the differences between the two approaches, you know, the data all says at about a month after surgery, everyone does exactly the same. So, like I said, I would find someone that you feel comfortable with that is gonna, because you're making a bond, you know, for the duration of this implant and the rest of your life. So someone you feel comfortable with that you trust. I think that's the biggest thing to consider.
So what typical from the front then?
I would say if you look at all the surveys when we go to the meetings, it's probably getting to be about 50-50, maybe 60-40 from the front. And then it depends on where you are. There are a lot of people here in Chicago that still do it from the back and do a lot of surgery, you know, at a high volume, and their patients do very well. Nationally, you're probably seeing it's probably closer to about 50-50, where maybe 10 years ago it was probably 20-80, maybe even less anterior. Yeah.
How do you know, is it after you have the MRI that you know which way you're going?
It's when I meet the patient and see their anatomy and kind of see what they're dealing with. That's how I typically decide. Yeah. And like I said, I think most people an anterior approach is a good option. But there are different risks for each one. You know, there are pros and cons to each one. And so it's really just trying to make the best decision for each patient. Every patient isn't the same, you know, and I think keeping that in mind is important. Yeah.
Certainly, the therapeutic process afterwards.
So typically, we do, it'll be about 6 to 8 weeks of therapy afterwards, is the prescription that we give. What I find is some patients they get better a lot quicker than others. So I've had patients who at 6 weeks are completed their physical therapy and, you know, they've kind of gone back to doing most things. And then I have patients at, you know, 8 weeks who are still working through things. The things that kind of drive that, it depends on where you were before surgery. So if the patients who were most active before surgery have a pretty quick recovery. The patients who had really severe arthritis, people who, if you're using a cane, it takes you a little longer to get to not using anything at all. You know, as opposed to if you weren't using anything, you kind of get back a little quicker. But overall, you know, even my patients that have really severe arthritis after a hip replacement, even if they're still working through therapy, their pain improves fairly quickly. I would say a hip replacement is an amazing surgery as far as its ability to really address hip pain, hip arthritis problems, even as you build back your strength. It really is amazing how well some people do. Yeah. Any other questions before I move on?
That metal cup that you insert.
Yeah.
How is that fastened? Is that sewn or glued?
How does it stick to the body? So it's coated with a special type of coating that actually the bone, it's made so that the bone grows into it. And so the bone and the metal bond together. And then me personally, I put a screw or 2 screws in every patient. So it gives it an initial kind of attachment to the bone. And then over time, it usually takes about 6 weeks. The bone then grows into the implant. But it's crazy. Once you put it in, you can't get it out. You put it in and then it's already stuck as soon as you put it in. So it's just these special materials that allow the bone to grow into it and interdigitate into the implant. Okay.
I have a question.
Yeah.
So what happens if you have a redo? You have to.
How do you get
take
it out?
all of that out?
It depends on why we're doing the redo. But sometimes, yeah, you have to take everything out, and we have special tools. Yeah.
We'll do that.
Yeah, luckily, I would say, redos are fairly rare. They're not a common thing. There are different, of course, there are complications that can happen, but all of those are less than 1%. And the new materials that we use now, some of the things that used to happen fairly commonly 15 years ago, we really don't see anymore, which is great, for the patient and great for us, honestly. I think you have first.
I was told that, a lot of the replacements now are using ceramic. So,
That is true. So in the hip replacements, I think the vast majority of people, probably over 95% of people, if not higher, are using that ball that I showed you is a ceramic ball. There were some issues 15 years ago now where people were using these metal balls, and they've had not everyone, but they have a little bit of issue there. So we've kind of gotten away from that. So we're doing ceramic balls. Yeah.
that's the part, also the ceramic goes into the femur also.
So the ceramic, let me show you again. So this piece is all metal, and then this pink ball, which is actually the color it is, this is ceramic. So the issue used to be that there was a metal ball sitting on this metal here, and you'd have issues with the metal rubbing on the metal. So that's why we've gone to it being ceramic, so now we don't really have that reaction anymore. Yeah.
And the cup is metal, but it's right.
It's metal. Cup is metal. Oh, it popped out. So yeah, the cup looks like this. It's metal.
So everything is metal except the ball. Why is the ball?
Because none of the metal is rubbing on the metal. The issue was the metal rubbing on the metal. So now we don't have any metal surfaces rubbing on metal surfaces.
What would be the problem? Metal rubs on metal.
So what we were seeing is that the metal rubbing on the metal could cause the metal to kind of wear away. Corrosion where the metal was hitting the metal. So that's why we've gotten away from that pretty much completely. Yeah, and then I got you.
As if you have that 30 different.
Mm-hmm.
A lot of times if you're getting ready to have a CT scan or something like that, they'll ask you, you haven't needed that can you still proceed?
You can. All the implants are MRI compatible. Now, what they do cause is in the picture, they can cause an artifact. So it's difficult to do it, to get an MRI around a hip or a knee replacement. It's hard to see the structures around it. But it doesn't actually mess with the machine or stop you from getting any sort of imaging done.
Here's one for as far as the knee.
Mm-hmm.
You mentioned prior to surgery, physical therapy. Is there any type of physical therapy that would assist with bone on bone as far as the knee?
So, that's a conversation that I have with my patients. I think physical therapy can be helpful, but at some point, if I have a patient that comes in and they have severe bone-on-bone arthritis and very little motion and all these things, is physical therapy going to take care of that and resolve it? Probably not. And so in my practice, it's usually a shared conversation and shared decision. Some patients want to try it. I think for some people, and I think early arthritis, moderate arthritis, I think it's a good thing to consider. But if I'm being honest, there are sometimes you try physical therapy and it makes people have more pain. And so, but it's hard to know. I don't know that before I send someone to physical therapy. So sometimes I'll offer, but I have patients that they had a steroid injection and they have very severe arthritis, and I say I don't know that even trying another injection works. I don't know. I don't think it makes sense to try it. I think you're at a point where you have one option left. Yeah.
Does that ceramic ever crack or custom?
Oh, that's a good question. So there used to be issues with ceramic cracking. And mostly it was if we were doing ceramic on top of ceramic. The new ceramic that we use really have that. Yeah, we've gotten so much better at our materials. over the years. The people that came before me did a lot of trial and error, and they've gotten it right. So the new ceramic we use really doesn't have those issues of like the fracture of the ball. That's not something that we really see, luckily. Yeah. What else? Any other questions? Okay, good. Keep going. All right, so we're on to the knee now. All right, so in a knee replacement, what we do is we remove the cartilage from the end of the bone here and the cartilage from the top of this bone. And then you put this metal cap that goes on the end here and this metal piece that sits inside the bone and a plastic piece in the middle. Okay. And then for people that have any issues with their kneecap, which is most people have some evidence of arthritis behind the kneecap, we put a similar plastic piece on the undersurface of the kneecap. And that allows for everything to move smoothly. We fix this to the bone using bone cement. And then in some patients, usually younger patients or people with really strong bone, will you do a similar process to in the hip where it grows into the bone? But I would say that's done less, but it's becoming more popular. One type of knee replacement that I think is important to touch on is a partial knee replacement. So we think about the knee, there are 3 parts to the knee, and sometimes we can replace just one of those parts. And it all depends on the patient and where their arthritis is and where their pain is. And so a partial replacement like this, instead of doing the whole tibia and the whole femur, we'll just do one part. And this is for patients that don't have any arthritis anywhere else, and who only have pain in that one area. And there are some benefits. There's a smaller incision. Patients do really well. They report that the knee feels better. But if done in the wrong patient, sometimes you can have to have, there are a portion of patients that end up needing to go to a full knee replacement. I think this is a great surgery for the right patient if they really only have isolated arthritis.
Yes,
Yeah.
then the X-ray imaging would determine
Yeah.
which one.
What they need, yeah. So when I look at an X-ray, I can see, okay, there's arthritis in this one spot, but there's none here and there's none here. And then I take that and I compare it to my exam. Does it hurt here? Does it hurt here? Sometimes I have patients who it looks like it's only in one spot, but they have pain elsewhere, which to me says there's arthritis there that I just can't see on the X-ray yet. And so for those patients, I usually say, maybe we should consider doing a full. Now, there are some patients who have arthritis in one place and another place, but they say, the arthritis here is less. It doesn't bother me as much, and I want to do a partial because the recovery is faster and all these things. I'd say that's less common, but usually it's, if there's any sort of symptoms, if I'm concerned, my recommendation, I'm pretty quick to say we should do a full if I'm worried about there being any sort of other issues.
How often do you have patients who do a unilateral back to the other compartment?
It's not often. It's not often in my practice, but like I said, I really try to be really, really strict about it. I think when you look at all the data out there, about 10%. So you can say 10%, 90% of people get it and they have no issues and they do great. But about 10% is the number that convert.
How about with the meniscus part? Is that always there or is that replaced?
We take it out. Yeah, we remove it during the surgery. So during the knee replacement, we remove the meniscus and we remove the ACL. But we keep the PCL and the other ligaments in the knee. But the ACL and the meniscus is removed.
Don't have it anymore.
Yeah, you just don't have it. So that's what the plastic kind of recreates. Because the meniscus is there as a kind of like a cushion, a protective buffer. And so once we put in the implant, you don't need that as you don't need that anymore. So same in the hip, we remove the labrum to fit in all the implants.
Okay.
Yeah.
I have a question about this ACL. I hear that often with NBA players.
Mhm.
that they torn or broken their ACL.
Mm-hmm.
I always thought that was in the leg by the ankle. That's,
Oh, no, that's in the knee. Let me show you. You're thinking the Achilles. Yeah, so where is it?
well,
So if you look on this picture on the left,
okay.
you see that pink stripe in the middle?
Yeah.
That's your ACL. Yeah, that's your ACL.
And then the meniscus is.
Is that blue? That's that blue thing.
Yeah,
Mhm.
that's on top.
Of the bone. That sits on top of the cartilage on the shin bone.
So when that gets scraped, is that the beginning of the end?
You can sometimes have a meniscus injury that is related to arthritis. Oftentimes, as the cartilage wears away, the meniscus gets, more damaged because it's taking on more of the load because the cartilage isn't working properly. So you can definitely have meniscus tears that are because of arthritis, but sometimes, you twist your knee and you tear a meniscus. It can happen both ways. Yeah.
So as it relates to the knee, if pain is just on, say for instance, the inside,
Mhm.
no pain or not. Is that an indication that you just may need that partial?
It's possible.
But I still need the whole thing, just that.
It's possible, depending on if when you also look at the x-rays, it only shows arthritis in that spot. Because if I saw, if I had someone who only had pain in one spot but had arthritis all over, I'd worry that the pain is gonna come. Yeah. Mm-hmm.
Could you just be out with partial replacement, or would you recommend?
If someone had a torn meniscus but not much arthritis, I probably wouldn't recommend a joint replacement yet. I would try to just treat the meniscus, which oftentimes, honestly, we can treat with physical therapy and injections and get it to settle down. It's when there's a meniscus tear and arthritis that we get concerned. And once again, it all just depends on where the arthritis is. If it's a meniscus tear on the inside and arthritis on the inside and really nothing else, then yeah, they might be a good candidate.
Bone on bone, that sounds like that needs more of a focus.
So oftentimes when it is that severe that it's bone on bone in one part, there's severe arthritis somewhere else. Oftentimes. Yeah. So, I'd say I see a little less rarely that it's really severe bone on bone arthritis in one spot and then nothing anywhere else other than really behind the kneecap. You see that for.
I had arthroscopy in 2019 because my knee went backwards and I pushed it forward. Well, and then it tore the meniscus.
Mhm.
And then when doctor went in, he said, "Oh my God, it was so much arthritis." He couldn't believe it,
Yeah.
So it took him a long time to be in there.
Yeah.
Yeah.
Okay.
Yeah.
I gotta ask this.
Yeah.
We hear arthritis. I've heard it almost 70 years, I think. Where does it come from? Is it genetic?
There's a genetic component. There's depends on what kind of activities you've done throughout your life component. There's a bunch of different things that go into it. Vast majority of people are gonna have some amount of arthritis. Some people have arthritis and it just doesn't hurt. I have, and it's funny when I see it because I'll have patients who come in and they have this really, really severe arthritis and and they're like, yeah, I think I just twisted my knee. It just started hurting like a couple of weeks ago. And, it's not a process that happens that quickly. It's something that happens over years and years and years. Everyone is just different. But a lot of it is genetics. And then a lot of it, I think at least, is what kind of, activities, we see people who are runners, high impact activities tend to get arthritis. If you've had injuries at a young age, like I had a meniscus tear when I was in high school. My knee hurts. I think I'm probably going to need to have a knee replacement at some point. But that kind of trauma, different amounts of trauma to the knee over time can lead to it as well. Yeah.
Can you go over the piece of plastic that you use to replace the cartilage?
Mm-hmm.
So if you have a partial,
Mm-hmm. Mm-hmm.
Remove some of the cartilage.
Yeah, so. Yeah, let me, it's a little smaller. I'll kind of come show you guys. So this is kind of what it looks like, where you have all the cartilage that stays on the one side. And then just on the inside is where you replace the damaged cartilage and put in this smaller piece of plastic.
You have to shape the plastic to match the contour of the bone or so.
So what we do is, we have different guides and stuff that kind of help us to size things. So we cut based on the size of the metal that we're putting in. And then these companies have like taken millions and millions of x-rays and CT scans, and they've kind of figured out a way to shape the implants so that they fit the vast majority of people, pretty spot on. Yeah. It's a good question. Yeah.
You hear the term arthritis. What is arthritis?
Arthritis at its most basic level. Arthritis is damage to the cartilage such that the cartilage that protects the end of the bone is wearing away. And it's usually meant to be like a degenerative, like it's the cartilage is breaking down. It's a cartilage disease essentially. Where the cartilage is wearing away. And, let's say you start off in your teen years where you have 3 millimeters of cartilage, and over time, which is thin, but over time to wear that away just through life, and you wear that away to the point where, you have the bone underneath exposed.
So based on that picture on the right.
Mm-hmm. If you needed a hip replacement, if you're having issues if you come in and you're like, my groin hurts, my groin into my thigh. Rarely I'll have patients say my knee hurts. Yeah. So it's, the pain, because the pain is coming from here. And so, people often will say, well, my hip hurts. And then I have a little pain here, but really where this ball ends up, it's kind of like right in this spot. And so that's where that pain will be, is in the groin, when the hip is acting up. Sometimes people will say, I have pain back here, pain on the side, pain on the side, like right here. And that's usually bursitis, which, patients that come in with a severe pain on the outside, and inability to sleep because they can't lay on their side because it hurts so much. And that, all those things I know, that's probably bursitis because it's all on the side. But that groin pain is usually the hip joint. Bursitis, we usually do physical therapy. Physical therapy. It's the key, is making those muscles stronger. Sometimes I'll do an injection, but physical therapy is the big thing. And then gentleman in the green had his hand up.
So there's no medications available to stop arthritis from progressing.
No.
So you lose the meniscus, goes away, and that's it.
Yeah.
There's no way to replace the meniscus.
There is meniscus replacement surgery, but you don't want it. Yeah. It's, there, unfortunately, arthritis is one of those things that we haven't figured out how to like really replace the cartilage in a way that is meaningful and like allows you to do everything that you want to do. Or even, I think honestly, like some of these things, the recovery for something like that, even let's say someone gets their meniscus like repaired, those patients, they have to, sometimes they can't put their weight on their leg for a certain amount of time. They can't bend the knee. There are all these restrictions, and you get like, let's say you get a knee replacement and you kind of start, there's no restrictions. It is a long recovery, but I think even some of those options are honestly a harder recovery. I have a patient who has arthritis, but also has a torn ACL. And it's like, well, my knee feels unstable, but a recovery from an ACL is 6 to 9 months recovery. Although it sounds like maybe a smaller surgery, but it's 6 to 9 months, and I would expect someone with a knee replacement, you make recovery, make improvements out to up to a year, but at 3 months, I would expect you're doing pretty much most things. So, yeah.
I had this throbbing pain in my groin area, so I was blaming it for a long time on female problems or something like that, right? And so then finally I couldn't take it anymore. A year later, and my doctor said, let's do a scan.
Mhm.
And so I ended up with avascular necrosis in my right. Yeah, so my little thoughts that it was this female
Yeah.
problems, I was way off.
Or a hernia,
And said it was my head. I was like, my head.
Yeah.
I was shocked, and all over that, just throbbing pain in my
Yeah.
groin.
Yeah. That growing pain will get you.
Got me, yeah.
You speak to range of motion for a total knee replacement prior to and what a very positive outcome percentage wise.
Yeah, I don't know if I can give percentages, but what I do know is my best guess or expectation for what someone is going to get post-operatively for their knee range of motion is what they had before. So the minimum I want to get to, and up to a point. Some people come in, they can bend their knee, 140 degrees, and that's a lot. That's in like the 90-something percentile. But if someone comes in and they have a stiff knee before, we're really gonna have to work hard to regain that motion afterwards. Okay, and they're more likely to have less range of motion at the end of their recovery. Someone that had full range of motion beforehand, I'm more confident that they're gonna get their full range of motion afterwards.
One quick follow-up.
Yeah.
Depending on technology of today, a full knee replacement, how long would you expect that? Rest of your life, 20 years, 15 years?
Rest of your life. For the vast majority of people, rest of your life. The data that we have goes up to 25 years at this point for the current material that we use. Because what happened, say you've heard you get 10 to 15 years out of a joint replacement, it was the plastic that we were using, where it wore out after a certain amount of time. You have some outliers, but for a lot of people, after 10 to 15 years, we kind of expected that that's about the amount that the plastic is going to last before you need to have the plastic exchange. I would say for most people, unless, very younger patients, I would say, there's a possibility. But for, patients in their 60s and above, my expectation is that the plastic is gonna, last the rest of your life. The data we have is to 25 years, and at 25 years, there's essentially no wear of the plastic in the lab. I don't want to say, because that's what we have, but there's nothing that suggests that under normal circumstances, you should just need a new one because it wears out. Yeah.
For a knee replacement, is there anything that you cannot do after surgery?
I do not put restrictions on my patients. Every surgeon feels differently about this. What most people will, the thing that people caution against the most would be running high impact activities, basketball, stuff like that. For the vast majority of people who are getting a joint replacement, that's not of any concern for most people. When you get to younger patients, it becomes more of an issue. But personally, I don't really put any restrictions on my patients. If someone ran before, then I'd like them to run again. I look at joint replacements, and I look at all of this as, we're trying to make every attempt to maintain someone's level of activity and allow them to do the things that they want to do. And being, of course, mindful. If you weren't doing certain things before, maybe you won't be able to get back to that, but it's about maintaining where you are so that you don't give up a lot of stuff. And that's why, honestly, I encourage people to seek care for some of these pains and stuff before it gets to a point where you've stopped doing all the things that you like. Because it gets harder and harder to get back to those things at that point. But if there's stuff that, when I meet you in the office that you do already, that you want to keep doing, the goal is that you keep doing those things. Yeah.
You hear a lot of ads and commercials for PRP. Is that viable for this kind of thing?
PRP is getting more and more popular. My personal opinion, what is it? So PRP, it's plasma enriched protein. Basically what they do is they take your blood and they split it up into the different parts, and they take the plasma, which is the, kind of regenerative cells in your blood, and then they put it back into your body with the idea that those cells then kind of help to re-energize the joint and decrease pain and decrease inflammation. PRP, I don't know that it works any better than any of the other things that exist.
There's no surgery.
But there's no surgery. But it's similar. I look at it similar to a steroid injection, where you hope that it gives you a lot of relief, but it might not. Now, I've met a lot of patients who get relief from it. I've also met patients that don't. It's not like a magic pill. This is my opinion, and to people that do it or people that seek it, I don't think there's anything necessarily wrong with it. But I do caution, because it can work, but it might not. And insurance doesn't cover it, and I think if it does work, great, and if you just have to be aware that it might not, just because it's like any of the other injections, in my opinion, at least. Yeah.
There are the medications that the advertised for arthritis. They claim irritates, celebrate.
So those are medications that we prescribe. One that I use a lot is oh man, I just had a meloxicam is my preferred. Mobic, I think, is the generic name or the brand name. That's what I use. They're all anti-inflammatories and they work. I have patients that, that's my kind of first line prescription medication. Didn't work for you. You see, and so some people love it and some people don't. And then, some people love Celebrex and some people don't. I think one of the hard things about this is, every patient is different. And so you wish there was, hey, I got a magic pill that's going to get rid of everything. And it just doesn't work that way, unfortunately. Yeah. All right. I think you have a question?
Do you do knee surgery? Do you do it from the top?
I do an incision from the front. My incision, I try to make it a little smaller than the typical incision. And so my incision is probably about 5 inches, 4 to 5 inches, as opposed to like 8 inches. But what I found is, the doing it from the front, I think is the best access. Although, it is a scar that everyone can see, and kneeling, while not impossible, can be difficult. I do think it's the best way to get into the knee. I do it from the front.
So I'm so scared to go over my hip because the doctor's like, I live alone and my animals sure aren't gonna take care of me. And then I have to go to a nursing home after. And I don't wanna do that.
Yeah.
What do I do? Can I just go home after a hip?
So, once again, everyone is different. I try to get my patients home the same day as much as possible. I hate nursing homes. There's higher risk for infection. Patients don't do as well. My preference is always for patients to go home. And I think most patients can go home the same day if they're healthy and they have help at home. Now, it is difficult because you don't want to go home and be by yourself. But, if at least my thought, this is my personal opinion. Everyone has their different protocols, and I I defer to whatever their thoughts are. But my thought would be if you have someone that can be there for the first couple of nights just to help and be available, I think that's enough. But that's just me personally. But I try to avoid nursing homes. I just think people don't get as much therapy as they think. They don't get as much attention as they think. They're just not, it's not what it sounds like it's gonna be.
So these surgeries, hip and knee, these are outpatient surgeries?
Mhm. Outpatient surgeries.
And physical therapy starts right away, or?
So my protocol is that I have a physical therapist that comes to the house a day or two after surgery. And so let's say, so today I did a hip replacement, did the surgery. Once he was awake, I try not to do like a general anesthesia. I try to put people kind of like a twilight, like a colonoscopy. We do a spinal anesthetic. And so that lasts for about the amount of time that the surgery lasts. We kind of try to time everything so that by the time you're waking up, the spinal is wearing off. You didn't, you had kind of light anesthesia, so you wake up pretty quickly. And as long as your pain's okay, then we get you up and walking. And then, you work with physical therapy. They kind of determine that you're able to do all the things that you check all their boxes. And then, like I said, for people, if you're healthy, you know, my more elderly patients, I like to keep overnight just in case. But for most people, if you're healthy, you don't have anything that's too concerning that I'm worried that's gonna, limit you or affect you, then I think, going home the same day and then starting therapy at home a day or two after is a good option. But whatever is safest, I have patients who just want to stay, which I think is fine. Yeah. Want to stay in the hospital. I have patients who are like, that sounds good, but I'd rather stay overnight, which is fine. Yeah, which is, there's nothing wrong with that at all. I have patients who just want to stay. And sometimes I do think yeah, insurance will pay for it. Yeah.
So the process starts with an X-ray and an MRI, and then we make a determination.
So the MRI, I would say, is not usually a necessity unless the X-ray isn't obvious. Then sometimes we'll get an MRI, or sometimes people come in with an MRI. I have patients who their arthritis doesn't look so bad on the X-ray, but on the MRI, they have a lot of cartilage damage, or especially in the hip, where X-ray looks okay, but it's worse in the hip. The soft tissues are damaged. And for hips, we jump to hip replacements a little quicker than we would for a knee. For a knee, I was saying earlier, if you just have a meniscus tear, I wouldn't recommend a knee replacement. But for a labral tear in the hip and a patient that was over the age of 50 or so, a hip replacement is a great option. It's reliable and it lasts long. And so I do have patients in that bucket where they have a labral tear and they're like, I don't want to do injections, or you do an injection, it doesn't really work, and we end up jumping to a hip replacement. Yeah.
Is there an age limit for where you would do this kind of surgery?
Not really. I don't have a cutoff for age. It's rare to have a patient above the age of 85 that is interested in a replacement surgery. I think a lot, I actually do see a lot of patients in their 90s in the office who have bad arthritis, and I don't think any of them want surgery, which I think is completely fine. And I wouldn't force someone in. But I think if you had someone who was in their late 80s or early 90s and had severe arthritis, was active, and we had a conversation about, goals, and, they're extremely, they're painful, it's affecting their life and what they're able to do, I don't think it's a bad option. And I feel that way more for a hip replacement than a knee replacement, because a hip replacement, the recovery is a lot easier. For a knee replacement, there's a lot of physical therapy involved. There's a lot of other things involved. There can be some more pain involved with a knee replacement. And so, for an elderly patient, unless they're really, really motivated to go through that, I might not recommend that. But you know, I do I treat a lot of hip fractures, and for, a lot of those, I'll do a hip replacement if it's someone in their mid to late 80s, but they're active. I'll do a full hip replacement, and those patients do really well. Slightly different setting, but same surgery.
Just one, for the hip connection, is there cartilage in that socket connection?
Yeah, that before we do the surgery or afterwards?
You see the cartilage in the picture for the knee?
Yeah.
Is there cartilage in the picture here that you show for the hip bone?
So this whole white cap here is all cartilage in the hip.
Isn't that bone that,
This white, so the white is cartilage, and then the bone is this like more yellowish stuff. So this whole white area is cartilage.
the bone stops then, right?
And the bone stops right under it. Yeah, so cartilage is like a layer over the bone. The bone is under the cartilage. It's deep to the cartilage. Yeah. Yeah. You guys have great questions. A lot of great questions. Some of these, a lot of the stuff I'm going to talk about later. You guys have nailed it. All right. So this is what I was talking about with the size of my incision for who asked. I do what's called minimally invasive joint replacement. So the idea is I try to keep my incision smaller, really to decrease the amount of skin I'm cutting, the amount of muscle that I'm cutting, the amount of blood loss, and all those things. With the idea that there's a smaller scar and a quicker recovery, just because we're damaging less tissue. So you guys haven't brought it up. I did want to talk about robotics. Okay, that's another hot button topic. So what the robot is, and this picture on the right is actually an example of a type of robot, the Mako robot, that we use in surgery. And so really what it is, it's a tool that we use to kind of help plan the surgery and then make and do some of the portions of the surgery. But it's not like there's a robot that's operating independent from the surgeon. It's really a tool that's used during the surgery. Some of them will get an X-ray or a CT scan beforehand to help with surgical planning. It can help the surgeons increase their accuracy during surgery. The interesting thing is, while the accuracy can increase, really there hasn't been found to be any sort of specific improvement in patient outcomes with the robot. As far as when you ask patients how they're doing, patients that had a robotic surgery versus no robot, patients all seem to do about the same. We haven't been able to find where the improvement is, but it does help to increase accuracy. And I think specifically for really complex surgeries, I think it's a really, really good tool to add. I also think it's a good tool for surgeons that don't do a lot of joint replacements. And where they might have more outliers. I think it kind of helps to bring them into more consistency. But I don't think it's a necessity today. And so for me, it's something that like I said, for rare complex cases, it's something that I might use, but not something that I implement on my day-to-day for my surgeries. All right, so what to expect? So like we were talking about with the spinal anesthesia and the twilight, most patients go home the same day. Exceptions are older patients that are sicker that need to be monitored. I do go to a surgery center that's not affiliated with any of the hospitals, but those patients have to be, below a certain BMI, have, no certain medical comorbidities. And then, like we were talking about, patients that don't have help at home, where, they're not going to be able to kind of take care of themselves. And we may keep them overnight just to monitor. Okay. You're walking the same day. Patients do physical therapy before leaving the hospital, and everyone starts off using a walker and then progressing to a cane and then to nothing.
That's for,
Everybody
hip or knee.
This is for everything. Yeah.
So will all patients have to walk all the way through?
I recommend a walker, yeah, and starting with a walker, and everyone's different as far as how quickly you progress from the walker to using nothing. I've had patients, I usually see my patients at 2 weeks after surgery. I've had patients that at 2 weeks aren't using anything. I would say that's more rare. And then I have some patients that are still using their walker. The patients who are about ready to get rid of it, but they really do like having it for a little bit of extra security. So, I try to be general here because, my protocols might be slightly different from other people's protocols. But for me, I think it's okay to drive at about 2 weeks is usually when I let patients drive. Depending on which side we do and how the patient feels, somewhere between 2 to 4 weeks, 2 to 6 weeks is when most people are driving. After 6 to 8 weeks, I think most activities, it's okay to do. Usually around the 6 week mark is when I'm letting patients start to ramp up their activities. By then, I do expect people to be, for the most part, back to their normal day-to-day lives. Depending on the job, I kind of, we have a conversation about how long to be off of work. People who do very labor intensive work, I say try to give it 3 months if possible, if you can get it. I have some people who are like, I need to be back at work in 3 to 4 weeks, and we have a conversation about expectations and what you'll be able to do at that point. But usually I try to get people to take off at least 6 weeks, because there is a range for how people recover. Some people are on the earlier end, but some people are on the longer end. At 6 to 8 weeks, people are about 75-80% recovered. And especially for the knees, I think a lot of the hips come in at that point and they feel great. Some of the knees at 6 weeks, 8 weeks, they're doing everything, but they're still having some pain. They're still using Tylenol, they're still working on their range of motion. Really, people, 6 to 12 months, people are making recovery after both surgeries, but especially after the knee replacement surgery. The physical therapy after knee replacement surgery is so important. Because a lot of the satisfaction with the knee is trying to maximize how much range of motion you get. And so a lot of that comes with the therapy and strengthening everything around the knee. So contraindications to surgery. Anyone with an active infection, uncontrolled diabetes, any severe cardiac issues that are not well controlled and well managed, anyone with active vascular issues or poor circulation, where I'm worried about your ability to heal your incision. Malnutrition is another contraindication. Once again, worried about the ability to heal. If you're not going to be able to participate in your therapy. Active cigarette smoking for me is a contraindication. That's not something that everyone believes in, but for me, that's something that I will not operate on someone who's actively smoking cigarettes. And then BMI. I personally don't have a BMI cutoff. Once again, that's some people feel different. Some people's cutoff is 35, some 40, some 45. I think BMI is not a perfect science, and it really doesn't take into factors the entire patient. So it's a tool that I use. I think it matters to a point. But someone with a high BMI, let's say above 45, who is working on their weight and has none of the above things, and they're healthy otherwise, I think that's a good person, a good surgical candidate, because it's hard to go to the gym and work out and try to lose weight if your knee hurts, so I don't think that's a fair expectation. But a patient with, a BMI, let's say your BMI is 47 and your diabetes isn't controlled and there are other things going on, that's a patient that I would say, we should make sure that we're getting as many things under control as we can before we jump into surgery. Because the issues aren't when you just have one thing, it's when you're adding things on top of other things that I think really causes the issues. So we talked about some of these already. We talked about, am I too old? Am I too young for a joint replacement? For a knee replacement, we try not to do them, too young, just because, like I was saying, as far as things wearing out, I might be more concerned about a knee over time because the forces are different. But a hip, I think the youngest hip replacement I've done, it was in a 36-year-old. And so you can do a hip replacement fairly young, but a knee, getting younger than 50 needs to be a conversation. Too old, we spoke about that. How long will it last? I don't think most people, once you're over the age of 60, 55 to 60, especially for a hip replacement, are really gonna have to worry about needing another hip replacement. I think that number is gonna increase, especially for the hips as we get more and more data. Metal detectors. So people ask me that all the time about, going to the airport and stuff. You will set off. So if you go through the regular metal detector, it'll go off. But everyone kind of expects it, especially at the airport and stuff. You just tell them and they put you through the thing where you put your hands in the air. The implants are made out of titanium. And then like we talked a lot about the ceramic on the ball and then a high grade plastic, polyethylene. And then activity wise, the goal is that you can be as active, if not more active than you were before the surgery. Is really the goal. So a good candidate is healthy for surgery. They're motivated and committed to recovery after surgery. The expectations are reasonable for what you're going to be able to do afterwards. You have a good support system to help you through the recovery period, and that you've tried some sort of non-operative measures before just jumping into it. And that can be, just taking, over-the-counter pain medication. It doesn't necessarily have to be therapy and injections, but we should try something before just diving into surgery. So choosing a surgeon. Everyone has some sort of online presence these days. I would say try to do your research online first. Look at reviews, their website, their practices website. I think word of mouth is very important. If you have a friend who's been through this before and had a good experience, that's great. Also, if you've had a friend that's had a bad experience, I think that's valuable as well. Your primary care physician probably has, some sort of relationships or knows something about, surgeons in the area, and you can ask their opinion. They're going to have patients who've also been through the same thing, and they'll kind of know who's had issues, who's done well, all these things. I would recommend finding someone who their main focus is doing joint replacements. In my opinion, I think, kind of back to the robotics conversation, I think the more of these that you do, the better your outcomes are. That's what a lot of our data shows, that high volume person who they do joint replacements, that's their thing. I think they have more consistent and better outcomes. And so I would recommend finding someone who that's the main thing that they do. And then really finding someone that when you meet them, you feel comfortable with them, you trust them. Because as I said before, you're kind of entering into this lifelong relationship where, if down the road, if something does happen, that this is the person you're going to come back to kind of talk, to try to address whatever issues you have. Okay. When you see them, I would ask about what treatment options they offer, what their post-operative program is. I know it can be hard because everyone's different and you only know so much. But kind of, getting a feel for them and, the way that they run their program and run their team and everything. And then completely okay to get a second opinion. Meet someone, you like them, but you're just not sure, you have questions, get a second opinion, get a third opinion. You don't want to do this multiple times. You want this to be the one surgery you have on that knee or that hip. So feel free to really go out and meet different surgeons and kind of decide what you want to do. So just to kind of wrap it all up, worsening pain in the groin or the knees is a sign to at least get someone to check it out. Okay. And then when non-operative treatments aren't working, it might be time to start considering surgery. Various ways and approaches. There's an anterior and posterior approach. There's the different types of knee replacements, a lot of different things to consider. But when you are ready and you think it's time, I think find a surgeon you trust that has a good reputation. Okay. And I think the big thing, it's not normal to live in pain, and you don't have to live in pain. It shouldn't be an expectation that, as you age, you have pain and you put up with it. I think we have really good treatments these days, with high satisfaction in the high 90th percentile. I think keeping that in mind, if you do get to that point. Okay. All right. So I know we asked a lot of questions, but I want to open up the floor again, see if there are any other lingering questions. Yeah.
When you go into the surgery,
Mhm.
your own people like come with you and your team or whatever you wanna call it?
Yeah, how do I do it?
Yeah,
Yeah. So when I go to Christ, because it is a teaching hospital, I work with the residents there, but I have, I try to keep the team consistent. Okay, so when I'm at Palos Hospital, we don't have the residents there, but I have surgical assists that work with me. I try to work with the same people over and over again. The nursing staff and the surgical techs and all those things at both hospitals, we I work with them over and over again. And then the people that, we also have people that work for the companies that make the implants that are there during the surgery. And so I have the same people that come because they help to, if there are issues, they troubleshoot, they help as we're, putting everything together. And so I have those same people come with me and we have a really good relationship. So we try to find some consistency because I think that makes a difference in, how the surgery goes. It's a good question. I think we'll go here. Yeah, so last year I probably did about 500 if you combine the hip and the knee replacements.
I've been told that you have all Baker's systems over there.
Uh-huh.
Take care of that at the same time.
During the surgery, you do. Yeah, you kind of try to clear that up during the surgery. Yeah. Yeah, you do. Okay. I think you and then you.
Because knee stiffness, knee soreness,
Mhm.
swelling in the back of her knee. What's the likelihood that she has to go into the urgent care or see a primary care physician to see maybe your replacement might be an option?
So the swelling in the back of the knee sounds like a Baker's cyst. And what a Baker's cyst is so the knee, when the knee's inflamed, it makes a lot of fluid because it's getting unstable and the fluid is there to make the knee stiff. And the knee is causing itself to be stiff so it's not as painful because it hurts when it moves. So the knee gets stiff. And the Baker's cyst is the fluid kind of leaking out of the back of the knee. And then you can feel like a pouch of fluid in the back of the knee there. It's a symptom as opposed to a diagnosis. At least that's how I look at it. It's a symptom of arthritis. I would say if it's causing her issues, I think it's worthwhile to at least, talk to her primary or something like that and get an x-ray. You can go from there. And, you can always decide, I take Tylenol every once in a while and it goes away and that's okay. And you don't want to do anything, but at least then you know what's going on, and I think that's a good way to approach it. Yeah.
So after, say for instance, knee replacement surgery, is there gonna be a limp? Am I gonna be walking regularly? If I know a guy who had knee replacement and I ran into him a few months ago and he said he's gotta have it again. So he got the shave down some bone and so I'm just wondering how does that work?
So, the goal is that we have this thing we use. It's called the forgotten joint score, right? So the goal is that at some point you forget that you had a knee replacement. It feels like your normal knee. Your hip, it feels like your normal hip. You just forget. Not everyone gets to that point, if I'm being 100% honest. I think the goal and the expectation really is that no, you don't have a limp for the rest of your life, right? That you're able to do all the things that you want to do. And there are a certain percentage of people who don't get there, and you might, because it's not your natural knee, you might have little things here and there. You might have like a little twinge. Some people say when it's cold outside, they have a little ache. I've heard that complaint before. You might never get as much, let's say you don't get as much range of motion. So it might just not feel as good as your regular knee does. The other thing is people will have one knee that does great and they'll have one that doesn't do as well. And so they'll kind of have an issue there. So, I think oftentimes when I talk to patients about, they had a knee replacement and they still have some issues, I think one thing I always ask is, well, how is it now compared to before? And it's rare that someone says, well, it's worse now than before. It happens, but I would say it's rare that, even with, not saying your friend who's having to have it, some sort of repeat surgery, because that's something that we want to avoid. But, even people who are, like, it was never perfect. Usually it's a lot better than it was before, which I would call a success, not 100% success, but I would call that a success too. The goal is that you're back to doing everything you were doing and you have a pain-free knee. or a pain-free hip. That's the goal.
But it is possible you could be left with some type of deformity or one leg. Doing that.
Like where your walk is.
Yeah, but doing that before, you know.
You know, I think that's more rare than anything. To be honest. But there are things, you know, we didn't talk a lot about everything that could go wrong. But you know, I don't want to I wanted this to be a happy conversation. But you know, there are things that can go wrong. You know, that 1% that I talked about with, you know, complications, you know, that's still one person out of every 100. We're doing, you know, projected to do more and more millions of these surgeries every year. And so, you know, 1% can, you know, still be a fair amount of people. But I would say, you know, thankfully it's the rarity. I think, you know, 99%, you know, 95 to 99% success rate. I think it's still pretty good.
Now, this question just popped into my head.
Mm-hmm.
You got your models, they look great. So do I get a female knee replacement or is it one size fits all? I'm walking around with a band.
Yeah.
How does that work?
You know, it's funny. I trained with someone. I trained with someone who developed a female knee replacement, and it did really well. They don't use it anymore. But so what we do during the surgery is we open, let's say the knee, right? We open the knee and we have a bunch of different sizes. They're left and rights.
Bring them in
Yeah, they bring them in. And that's what the guys that work for the company are there. They kind of keep everything together. So they're not scrubbed into the surgery, but they're there. And so they bring all this stuff in. And so I can say, you know, for the top of your shin bone, right? I think it's eight sizes or 9 sizes. And I can put it down and say which one to me fits exactly perfect, right? And then the same thing for the femur. I say based on, you know, the size of your knee, which one of these fits right for your knee? And that's how we, it's a good question. It's a good question. One size fits all does not work. So we have, yeah.
In my case, with avascular necrosis, do I have to see a vascular surgeon? Or
No.
Like you could-
No, yeah, that's just something that an orthopedic surgeon would manage. Yeah. The reason avascular necrosis happens is because the blood flow to the ball of the hip is just it's all these really small, tiny blood vessels. So it doesn't take a lot for them to stop working. And so you know, the treatment is really, you know, eventually it's just a hip replacement. Yeah.
So are you accepting new patients?
Mm-hmm. Yeah, I am. Yeah.
We do this now and then. I'm all gone.
Yeah.
Show on the model of the knee, what parts you actually replace.
Yeah. So how about this? Let me. So if you look at this, all this white stuff, all that cartilage is what we replace. And then we make a cut like right about here, and then put a metal piece that goes on top, goes like inside the bone. And then on the under surface of this, I just wanted to point to it there, and I'll show you again on the model here. Because if you look at it from the side, you know, it's kind of like a cat going around the edge of the bone. And the reason we do that is that's where all the cartilage is on the edge of the bone. So we remove all of this around here and then come right here on the top. Okay? And then metal, and then that plastic in the middle there.
Oh.
Knee replacement surgery, a couple hours, 4 hours, 5.
Oh no, it takes about an hour and a half. Yeah, about an hour and a half to 2 hours. Yeah. So usually I would say, you know, we're in the operating room for about 2.5, you know, maybe 3 hours. It always feels longer than it is. But once we're in the room, you know, some of that is doing the spinal anesthetic or putting the patient to sleep, getting the patient positioned. There's a lot of other stuff that happens while we're in the room. But the surgery itself, you know, to put the knee replacement in, takes about, about an hour and a half.
How many do you do a day? Let's say you got your surgery schedule,
Mm-hmm.
and what's your limit?
Yeah, so right now, a lot of it is on the capacity of the hospital, but I do about 3 in a day. There are places where, you just sorry, yeah. I'll do about three in a day. Where I was before I was with Parkview, I was doing a lot more, but right now, yeah, we do about three in a day. Yeah.
Push you in getting medical equipment in your home following these seconds.
As far as like walkers and stuff like that. Yeah, so if you have surgery at the hospital. So the hospital does help with a lot of that stuff. For patients that go to the surgery center, then we help a little bit more, and they have a lot of stuff there too. But the hospital, you go to the hospital, get you the walker. If you need to get like a toilet seat riser and stuff like that, then they help to get all those things.
So
Social services as well.
as far as the kneecap,
Yeah, so the kneecap, similar to this, on the undersurface of the kneecap, where it's touching the bone right there, there's a layer of cartilage. So we kind of do the same thing where we remove it and then we place a little cap, little plastic cap that goes there. Yeah.
Class. Can you play with bones?
So what I do is I kind of go over everything with my patients. And then the hospital, so at Christ, they have a joints class separately. And so part of the process there is you have to meet with them. And I really like it because they review all your medical issues. They kind of make sure that there's no gaps, nothing that's been missed. Because a lot of patients, their primary cares are all over so the advocate will kind of look at everything again and kind of make sure all the T's are crossed and everything like that. And they talk about a lot of the things that I talk about. Usually patients will have seen them before they see me. And so it makes me going through my little classes very, very easy. Yeah.
What about the nerves? Is there any nerve damage?
Nerve damage is rare. So in the hip, the sciatic nerve, if you're doing a posterior approach, the sciatic nerve is in the area, but not something that we really see, or, it's fairly rare to get so close to it. It's kind of there and we know it's there, but we're not messing with it. What I do see in the anterior hip, sometimes people have a little bit of numbness on the front of the thigh. That's there's a superficial nerve that runs close to the incision. It's really close to the skin. So that's, sometimes people have a little numbness, but it usually improves. It doesn't really affect their strength or anything like that. In the knee, people who are kind of really knock-kneed, sometimes they can have a little bit of, as we straighten the knee out, we can stretch one of the nerves. Other than that, it's rare to see, really, really significant nerve damage. That's pretty rare. With the knee replacements, one thing that surprises a lot of people, there's usually some persistent numbness over the front of the knee. So the nerve that does sensation on the knee, it goes from the inside outside and crosses across the front. So when we do the incision in the front, the inside of the people can feel, and then the outside of the knee, they feel like they have numbness. It usually improves to some degree. There's usually around the incision always a little area that's a little numb. That's another thing that people, complain about. Yeah.
do you use a specific, knee replacement manufacturer?
Implant company? Yeah. So, for my knees, I usually use, it's called Zimmer Biomet, Zimmer Biomet is Zimmer, I guess, is the name of the company, or DJO or Innovis is the name of the other company. And then for my hips, I usually use Zimmer, or I use DePuy. DePuy Synthes is the other company that I use. Yeah. And so it depends on, there's subtle differences between the implants. I think one of the nice things is now all the implant companies have kind of caught up to each other. There's like these little subtle differences on, philosophies that they have and stuff like that. But as far as quality of the materials and all those things, they're all sort of, putting out pretty quality implants, which is good. Yeah. Anything else?
How often do you do double knees? Same.
Never, never. I wouldn't recommend it. It's the recovery is more than 2 times worse. You don't really get any benefit other than one anesthetic.
Yeah.
No. Mm-mm. No. Yeah, I don't think the benefit of, getting it done and over with, it doesn't make your outcomes any better or anything like that. So I typically wouldn't recommend it.
Waiting period maybe 6 months to a year.
So it depends on the patients. Usually if I'm doing both sides, I've had patients who we kind of come in and they're like, I want to do both sides. Around the 2.5 months, 3 months is when it ends up happening. But then other patients will say, I kind of want to wait. I think what I use to say it's time to do the next side is one, if it's just so severe, the pain that it's limiting their recovery because the other side is hurting so much, then I'd say maybe we should do the other side a little quicker. And then the other thing is sometimes people with really bad deformity, it becomes hard to walk once one is fixed. So like let's say your leg was really, you had a severe bow leg. This is one of my patients, severely bow-legged on both knees. We fixed one, and he was like, I can't walk because now one's straight, and then the other one I have to drop down. And so we proceeded a little quicker. So it's all patient dependent. But most of the time I would say I would wait until the first knee feels strong enough for you to depend on it to recover for the second, typically. Yeah.
Thank you so much.
Yeah, he's talking about the patient that's severely bow-legged and you straighten their knee. How do you do that?
I use kind of different landmarks throughout the surgery. I get x-rays that I do some preoperative planning. So I kind of know what I need to do to get, much straighter alignment. People are really, really bow-legged. I try not to make them straight completely. But I just kind of plan out beforehand. I get special x-rays and stuff that I can make all my plans are, and then I match that during the surgery. Yeah. Okay.
Very nice, thank you.
All right. Thank you guys so much. Okay. I have some cards over here. Feel free to grab one on your way out. We also have a little flyer there. Thank you guys so much for coming. Really.